Hello friends, this is from Chambers, and today we are also again going to teach the pharmacology. It's a pharmacology classroom, and we will be taking the discussion further on after the metabolism to enzymes and all, ending the pharmacokinetics in this video. So if you haven't watched the previous video, please watch that video before watching this video. So yesterday we said that there is a metabolism was happening, and we said that it is the primary site is the liver, where you are actually converting the inactivated form of drugs into the activated form. And we discussed about the prodrugs also, that those prodrugs, that is ACE inhibitors, prednisolone, proguanil, mercaptopurine, methyl dopa, minoxidil, irinotecan, isn't it? Clopidogrel, carbimazole, sulfasalazine, these all are prodrugs, and we have to make them active. They are in inactive form. It's only after the liver activates them, they will be able to show their effect, isn't it? So today I want to add some more to this, that, you know, these things, this metabolism is being done by some enzyme. So let us share the screen first. Let us share the screen. Let us share the screen. Okay. So if I show you, for example, can you see the screen? So see, we said metabolism is happening, isn't it? We said it is the third study, isn't it? Third study, absorption, distribution. Now we are studying about the metabolism. So this metabolism is not actually happening something in the air or something, some special angel is coming and doing this metabolism. It is basically because of some enzymes. So in the liver, you will be able to appreciate two types of enzymes. One is a microsomal enzyme, another is a non-microsomal enzyme. Non-microsomal enzyme. So what is this microsomal enzyme? Microsome means if an enzyme is present in the smooth endoplasmic reticulum. If an enzyme is present in the smooth endoplasmic reticulum, we say microsomal enzyme. If an enzyme is not present outside, we say it is non-microsomal enzyme. It's as simple as that. Okay. We said, in the metabolism part, we said in the last video that it is basically meant to make a drug water soluble. Why I am making a drug water soluble? The purpose is to throw it in the urine. Drug can be only thrown in the urine if you are making it lipid water soluble, isn't it? You have to throw it in the urine, isn't it? And also, so you are actually taking the metabolism step towards the excretion step. That is our fourth study, isn't it? Isn't it, my dears? So before studying this metabolism also, I talked about something called redistribution. I talked about something called redistribution. If I have talked redistribution, I said some drugs get lipid soluble drugs. If I have a lipid soluble drug, they will start getting redistribution in fat tissues. They will show they will show redistribution in fat tissues. That means if you have to eliminate the drug action, before that they will be showing a phenomenon called redistribution. I give you an example. See, we have a thiobenton, isn't it? This is an IV anesthetic, isn't it? It is an IV anesthetic. So I want to ask you, you know it reaches the brain. What is the time in which it reaches the brain? It reaches the brain in less than 1 minute. It reaches the brain in less than 1 minute. But what is the half-life of this drug? Its half-life is 9 hours, I think. What is the reason of this? It reaches the brain in less than 1 minute. That's not a joke. So can anyone of you tell me why this is happening? Why this 9 hour is the half-life? We said, if you are making anyway a storage form of a drug, be it in the plasma protein binding form or be it in the fat form, if you are binding something to the plasma protein, you are actually increasing the duration of action. You are actually decreasing its metabolism, isn't it? It is acting as a temporary storage of your drug. And if I talk about lipid tissue, your adipose tissue, it is storing your drug, isn't it? Because your drugs, if they are lipid soluble, they will be able to redistribute. Volume of distribution will be there. So it is because of the fat sequestration, sequestration in the fatty tissue, sequestration in the fatty tissue, that your half-life is 9 hours. But why is it going in less than 1 minute to the brain? Why is this happening? Why not with other drugs that this drug is going? No, it is less than 1 minute reaching the brain. What is the reason, my dears? Because blood has a high, you have a cerebral blood flow, isn't it? CBF. So blood is high blood flow towards the brain. That's why. Okay. Why, sir? If it is you are telling it about the brain, yeah, you want to have the central anesthetic action, isn't it? You need to reach it. You want it to get to the brain. But why your this is going less to the fatty tissue? Why you are having a lesser? Why is it slowly reaching the fat? Because fat has a less blood supply. Fat has less blood supply. Okay, fat has less blood supply. That's a beautiful. I like this mechanism. This thiopenton. Very nice mechanism. This is from my anesthetic part. So yeah, this is what is happening actually at this level. Okay, mostly all the CNS drugs. Mostly. I will not say all. Mostly the CNS drugs which we have. You know, their initial dose mostly depends on the redistribution. We are not more concerned at that time about the half-life, but more on the redistribution. Okay, so can I say it is due to the blood fat ratio that my CNS drug I have to see the blood fat ratio, how much blood flow perfusion is happening to that tissue? In that way it will be affecting the action, isn't it? Isn't it? So that means my second dose, my initial dose which I gave, that depended on that was depending upon the redistribution. But now the second dose which I give, it's applicable for CNS drugs also. Please remember, only CNS drugs I'm talking right now. Okay, so redistribution. But if I have to give a second dose, that second dose, at that time the rate of distribution will be less, and my second dose will have a longer duration of action. My second dose will have a longer duration of action. Okay, my second dose will have a longer duration of action. Are we able to understand? Okay, so this is how we are appreciating things. Okay, so I want to ask you another thing, the most confusing part, that is what is why this microsomal enzymes are having this, why we are saying that, what is the specificity about this microsomal and non-microsomal enzymes? Can someone add with me something? Can someone add with something? Why we have a two enzyme system, that microsomal and non-microsomal? Why we are classifying them? What is the reason behind this? Yeah, we should contribute. What is the reason behind this? Why we have microsome? Why we are dividing enzymes into the microsomal knowledge? So that we can know whether which enzymes will be induced and which enzymes will be inhibited and which enzyme will not be. We can't have any effect on them. That means, remember one thing, your microsomal enzymes, for example, your cytochrome P450, for example, your glucuronide transferase, your monooxygenases, they all are microsomal enzymes. And these are the enzymes. Remember, whenever you see, anywhere you see a microsomal enzyme, that enzyme can be inhibited also, and that enzyme can be induced also. That enzyme can be inhibited also, that enzyme can be induced also. But your non-microsomal enzyme does not have these interactions. They are not susceptible to these interactions. So you are worried about the microsomal enzymes, about these interactions. So for example, what your microsomal enzymes can do? They can do oxidations, they can do reduction reaction, they can do hydrolysis reaction, they can do conjugation reactions, isn't it? You can do deamination with that I will be teaching you in the phase 1 and phase 2. So we have two. We are structurally, we are saying that we have microsomal enzyme, and functionally, like metabolism. In the way of metabolism, we are saying we have phase 1 and phase 2 reaction. Like what we are we doing an anabolic state, or we are going into the catabolic state? Okay, so let us write like this. So your microsomal enzymes is equal to smooth endoplasmic reticulum, means microsome. It depends on the centrifuge. You may have read it in the biochemistry that we are centrifuging something and we are getting then a microsome. So this microsome, and then we can write that it is inducible and can be inhibited too. Can be inhibited too, isn't it? But if I write about the non-microsomal enzymes, means they are not present in the microsome. So if they are not present in the microsome, that means they are present outside the microsomes, outside the microsome, that is outside the SER, that is not inducible, not inhibited, not inducible, not inhibited. Okay, only microsomal enzymes can be inhibited and induced. Remember this thing. How we will understand? Okay, is it clear? Very nice. So now look at me. Look at me. Full concentration of yours I require right now. If we want to metabolize something, we say from our biochemistry, basic biochemistry, we say it is substrate. The thing on which we are doing something, that is a substrate which you are going to metabolize. So you usually used to write a reaction like this. Here you had a substrate, and here you had a product. Traditional way we used to say this is a substrate gives products. In between them, someone will be doing something, that is an enzyme. That means a microsomal enzyme will work on a substrate and convert it into a product. So there is now a thing, either I can increase the number of enzymes, either I can increase the number of enzymes. If I increase the number of enzymes, that means I am increasing the number of workers in a factory. That means I will be making more televisions. I will be making more televisions. You give me a circuit, if I have 50 circuit, and if I have 100 people, this is nothing for them. 50 circuits for 100 people is nothing. That means 100 enzymes and 50 substrates. They will they will give you the products in less period. They will give you in such a way that you will be you don't need to wait for them, or you don't need to wait the reaction to happen for a long time. That means in one way I can increase the number of enzymes. I can increase the number of enzymes. There is a big wrong concept in the world that inducer is increasing the efficiency of enzyme. A very wrong concept. I have seen in various institutions being taught this thing, that I myself get confused. They say they increase the activity of enzyme. It's wrong. It's totally wrong. We are not here talking in the in the concept of inducer and inhibitor. We are not talking about the inducer is stimulating something. It is wrong concept. Inducer is basically increasing the number of enzymes. Can I say it is increasing the gene expression of the enzyme? If I go into the biochemistry integration, can I say they are increasing the gene expression of these microsomal enzymes? So remember one thing, please write a big statement with a red pen, that inducers are increasing, they are increasing the gene expression of microsomal enzymes. If I have an increased gene expression of microsomal enzymes, these microsomal enzymes will be more. If I had 10 microsomal enzymes, now I'll have 100 enzymes. It is not that I am doing something to one enzyme and telling him to make many products. No, it is actually the number of enzymes which we are increasing with the inducer. And same way goes this statement goes for the inhibitor, that you are decreasing the number is to be mentioned, decreasing the number of the enzymes. Meaning thereby, if I am giving an enzyme inducer, It means I will have more enzymes, means my metabolism will increase, means my drugs will be metabolized more, means their effect will decrease because I am metabolizing them more. That means their effect will decrease. That means their effect will decrease. I'm actually decreasing their effect. Can I say that I should increase the dose of those drugs whose effect is getting decreased? So once I am giving, for example, as being a physician, I am telling, I am giving some patient, for example, I am giving some patient a statin. Okay, I am giving this statin, atorvastatin, pravastatin. I am giving this for lowering the cholesterol levels, lowering the hypolipidemic agent. What will happen is now the patient is already having an epileptic. He's an epileptic. He is a patient of seizures, for example, and he is taking phenytoin, for example. He is also taking phenytoin. From the concept of cytochrome P450 enzyme, I know this statin is metabolized by enzyme subfamily cytochrome P3A4. Cytochrome P3A4. Now this cytochrome P3A4 is converting this statin into product. But what is happening? This phenytoin, he's taking both drugs, isn't it? He's already a patient of epilepsy, and he's also a patient of hypercholesterolemia, hyperlipidemia, and I have to give him both the drugs, for example. What will happen is this statin is getting metabolized by cytochrome P3A4. This phenytoin is an inducer of cytochrome P3A4. What will happen now? If this is an inducer of cytochrome P3A4, that means my cytochrome 3A4 will increase. I will have more amount of 3A4. Means my statin will get more metabolized. Means should I say I have to give high dosage of statin if a patient is taking phenytoin as being a physician? Should I say I should initially I have to give the dose of high amount of statin if the patient is already taking phenytoin? Can I say that if a patient is taking statin, I should give him rifampicin? No, rifampicin he's also taking. He's a TB, tuberculosis patient, and I am giving him rifampicin. Should I increase the dose of statins? Should I increase the dose of statins? I want answers, please. A contribution. So this is the concept behind this inducer and inhibition mechanism. This is the concept behind this. Now let me tell you one thing. There is, then we have to remember those enzyme inducers and enzyme inhibitors, isn't it? We have to remember them. So how to remember them? There are so many mnemonics, like some are most chronic alcohol, steel, fan, and never get greasy carbs. Some remember by what? Some remember by this girlfriend, for example, like this. Girlfriend. Girlfriend. You say in the Desi people, they say friend, not friend. Girlfriend. Okay. Girlfriend received cell phone. S, you can write anything. Okay. Girlfriend received cell phone. Okay. So what is the meaning of this girlfriend received cell phone? These are the enzyme inducers. Means these drugs are the inducers of enzyme, meaning thereby they will increase the number of microsomal enzyme, meaning thereby they will increase the metabolism of the drug, which is the substrate of that particular enzyme. Meaning thereby I have to give the higher dose of that substrate, not the inducer, substrate, because substrate is getting more metabolized. Substrate is getting more metabolized means I am breaking the substrate more, means I am having that decreasing the effect of the drug, meaning thereby I have to give the highest dose clinically once I am giving it with an inducer. If we are not using any inducer, or now let me talk about the inhibitor. Now in the inhibitor case, I am increasing what? In the inhibitor case, I have to decrease the dosage of substrate, isn't it? Because inhibitor will decrease the number of enzymes and it can lead to toxicity. So what I will do, I will decrease the dose of substrate, isn't it? My dears, like this, you are not replying me. See, this is a drug. This drug is, for example, let us take which drug should I take? Okay, I take a beautiful example, by the way. Um, Okay, take me. I should take phenytoin. Okay, let me take a phenytoin. Now this is a phenytoin. Phenytoin is a substrate of which enzyme? 2C9. How I remember? I learned them long back in my pharmacology. Like cytochrome 3A4, the substrate is, CT scan drugs. That is cyclosporin, calcium channel blocker, tacrolimus, statins, cat drugs also, cisapride, estamizole, terfenadine, isn't it? Amiodarone and Navirs. What is Navirs? What is Navirs? Navirs means protease inhibitors. Protease inhibitors. And then which drugs are metabolized by 2D6? I'm giving a rapid review. Okay, 2D6, all your antidepressants, for example SSRI reuptake inhibitors, your MAO inhibitors, your TCA tricyclic antidepressants, your beta blockers, your antiarrhythmics, these are all substrates are being metabolized by 2D6. If you talk about 2C19, now see how to remember 2C19 substrate, how to remember these groups. Cl means, this is not Cl, we remember like this. Cl means clopidogrel. Okay, are you able to understand? Okay, 2C90. Okay, so clopidogrel and omeprazole, it's a proton pump inhibitor, isn't it? Which enzymes will which substrate will be metabolized by 2C, not 9, now 19. Which? C means clotting. C means clotting. So clotting stands for which? I remember warfarin. Warfarin is an anticoagulant. How I remember other things? Tolbutamide. What else? Phenytoin, isn't it? And which drugs are the substrate of 1A2? 1A2 is warfarin theophylline, isn't it? Which drugs are metabolized by 2E1? What is A? A means, A means acetaminophen, acetaminophen. E means anfluran. H means halothane. This is how you have, you don't have to learn them. It's just the concept that you should have, that what drugs will be used by this enzyme. And you have to remember the inducers and the inhibitors. So how to remember inducers? There is now the mnemonic for inducers and inhibitors is this. This is the mnemonic. So G stands for griseofulvin. Griseofulvin. P stands for, let me write in a clean way. Otherwise, people get naraz with me. They get sad with me. P is phenytoin. P is phenytoin. R is rifampicin. What else? C is carbamazepine. Carbamazepine. It is the drug of choice for trigeminal neuralgia. It is a drug of choice for trigeminal neuralgia. Favorite neurology. Carbamazepine. CBZ we write in the brackets. What else? P for phenobarbital. Phenobarbital. What is the meaning of this, sir? Why we are learning these drugs? The reason is these drugs are the inducers, potent. I will write potent inducers. They are the potent inducers. Sir, what is the meaning of potent inducers? Means when they go to the liver, they will increase the number of enzymes. Cytochrome P450 enzymes. They will increase their level. Once they increase the level of cytochrome P450 enzymes, that means I have more enzymes for less substrate. Substrate comparatively will get less. That means I will have more metabolism of this substrate, meaning thereby the substrate will have less effect, that they will decrease the effect also. So I have to give, once you are giving an inducer, you have to increase the dose of the substrate so that you can balance it very well, so that your plasma concentrations of effective plasma concentration does not get decreased. Are we able to understand? Is it clear from the live students, please? I have explained it at least 3 times. And once you watch this video again, you know, scroll back again, it becomes 6 times. Once you again scroll, it becomes 9 times. Are we able to understand? So this is the concept behind this. So let me take inducers also, inhibitors also. What are the inhibitors? There is a famous mnemonic called sickfaces.com. Sickfaces.com. But we remember sickfaces.com. What else? What else mnemonic we have? What else mnemonic we have? Vitamin K cannot cause something like inhibition, isn't it? Vitamin K is not able to do enzyme inhibition. Will the vitamin K inhibit this enzyme? Have you read somewhere that vitamin K inhibits this enzyme? Have you read somewhere? Just tell me yes or no. Have you read somewhere vitamin K? Please. Why people are not answering? What happened? So yeah, you haven't read. So you should say yes, sir. We haven't read. So that's how you can remember that vitamin K cannot cause enzyme inhibition. So vitamin K. So V stands for valproate or valproic acid. Valproic acid used for anti-epileptic mostly. Ketoconazole, antifungal. Cimetidine, H2 blocker, isn't it? Your antacid. No, it decreases use. You can use it also in the peptic ulcer disease. Ciprofloxacin. What else was there? Vitamin K cannot cause. I have to write erythromycin. So enzyme isoniazid, isn't it? So enzyme inhibition. So enzyme inhibition is erythromycin. So these are the mnemonics you have to remember these drugs that you, if once you are giving these drugs for something, you have to remember that which drug should I have to increase the dosage or decrease the dosage. So if these are inhibitors, then I have to decrease the dose of my substrate which I'm already taking, not of this. You just have to think about the substrate. Okay. So there is one concept which we see in our clinical practice. The thing is, first I should tell you which enzymes, microsomal enzymes, are doing what. Okay, let us make a small table for them. Okay, so let us write like this. So your microsomal enzymes, what else can they do? First I will tell you some phase of metabolic reaction. Let me write like this: phase of metabolic reactions. Phase of metabolic reaction. What is this phase of metabolic reactions? Means metabolic reactions which a liver is doing, we are classifying them into two phases. One is a synthetic phase, another is a non-synthetic phase. Synthetic phase is phase 2. Non-synthetic phase is phase 1. What is the function of phase 2 synthetic phase? Means I am making something. What in the phase, if I talk about phase 1 will attach a functional group. This reaction which is happening in the liver, this reaction will attach a functional group to my drug. This is a drug and it will attach this functional group. This is a drug and now this functional group is getting attached. Functional group is getting attached to this drug molecule. But if I talk about phase 2 reactions, they do conjugation. They attach a conjugate. So conjugate for the synthetic phase. Means, what is the meaning of this, sir? If you tell me in that, no, apart from a chemistry student, what to say? To make the things easy, I will say, in the phase 1 non-synthetic phase reaction, the drug may become water soluble or can become lipid soluble. In a phase 1 reaction, a drug can become water soluble or lipid soluble. But phase 2 reactions make the drugs always water soluble. Phase 2 reactions always make the drug water soluble. That means lipid dash. If I am selling phase 2 reactions make a drug water soluble, that means lipid, it is making the drug lipid dash. This is not the answer. Lipid insoluble. That means it is making the drugs lipid insoluble. Okay, so I should write the phase 2 reactions, that is the synthetic phase. Is making the drugs fully, all the drugs will become water soluble. But if I talk about phase 1 reaction, it can make either water soluble You can make a drug water soluble or you can make a drug lipid soluble. So where will you be definitely full confident that you will have a water soluble? Which phase will give you a confidence that you are fully water soluble? Phase 2 or synthetic reaction, phase 2 or synthetic reactions. So which reactions will make a thing water soluble? Let me tell you. Do you remember the bilirubin, unconjugated bilirubin, UCB? Do you remember UCB was getting converted to conjugated bilirubin? Which bilirubin is water soluble? Which bilirubin is water soluble? Yeah, glucuronidation reaction. Very good. So who is water soluble? This conjugated becomes water soluble. That's why you are able to throw it in the urine, and also urobilinogen and stercobilinogen, isn't it? So if it's an unconjugated, you have that unconjugated hyperbilirubinemia. You're not able to convert it into water soluble conjugated bilirubin form. So that you also call that indirect and direct bilirubin, isn't it? So this conjugated, that is the way you have to remember that. First you should write the example is conjugation reactions. Conjugation reactions. What else are synthetic? Conjugation reaction which? Glucuronidation, isn't it? You have that glucuronyl transferase in your liver. So glucuronidation. What else? Acetylation. Acetylation are phase 2 reaction. What else? Glycine conjugation. You know glycine conjugation in your glutathione. Glycine conjugation. What else? Methylation. Methylation. What else is a phase 2 reaction? Sulfation. Sulfation. What else? What else? Yes, please. These are sufficient. Okay. So what is the phase 1? Which reactions are in the phase 1? Your hydrolysis, your oxidation, reduction. What else? Cyclization, deamination. Can you see the difference? Methylation is a phase 2, deamination is a phase 1. Okay. The question asked will be, what is the most common phase 2 reaction? What is the most common? It is glucuronide conjugation. Just write it here with a blue pen. Let us make you write this thing. This is the most common phase 2 reaction. Most common phase 2 reaction. Okay. How people to understand? Who is having a problem? You know what these cytochrome P450s are? You have, these are enzymes. These are family actually. What is the meaning of this CYP, by the way? CYP. CY means cytochrome. P means pigment. Means 450 is a nanometer. 450 is a nanometer. What? Absorption. Light absorption which it can do at a wavelength of 450. Okay. So what is the meaning? Like if you are seeing that they are writing CYP, so this is a cytochrome P. And if they write the first number which comes, it tells me the family. So here will be a family. Then we will have what? Alphabet. So what is that alphabet? Alphabet will tell me subfamily. Alphabet will tell me the subfamily. And if another enzyme is there, it will tell me the isoform of that enzyme. Isoform you have read in the biochemistry. For example, I am telling cytochrome 3A4. Cytochrome 3A4, CYP3A4. So what is 3? 3 is a family. 3 is a family. What is A? If you see, for example, cytochrome, if you see a cytochrome P2C19, it means cytochrome is a cytochrome. 2 is the first numerical. It shows the family. This is a family. C is a subfamily. 19 is a isoform of this. Okay, are we able to understand? So let us talk something about, I want to write some enzyme inducers and inhibitors, some important enzyme inducers. So if we talk about cytochrome 3A4, if we have cytochrome, this cytochrome is maximally metabolizing your drug. Your maximum drugs are being metabolized by this cytochrome P3A4. Okay, so this cytochrome P3A4 is actually PDR drugs. What is PDR? You can tell me what is PDR? Physician's desk reference. Desk reference. Physician's desk reference. No, mostly all the drugs, at least around, I think 70% or something around that will be in the physician's desk reference. Okay, and this 3A4, if we talk, we have a famous mnemonic for this, that is CT scan. So CT scan drugs are getting metabolized by this 3A4. So what is CT scan? C is C square, T1, S1, cat, A, N. So C square is what? What is C square? C stands for calcium channel blockers. Calcium channel blockers. This is cyclosporin. Cyclosporin. Okay. T raised to the power 1 means T is 1. I remember like this. So tacrolimus. Tacrolimus. S means statins. S means statins. Statins. Okay. No. Atorvastatin. Pravastatin. And CT scan. C is cat. So cat is here. Cat means C for cisapride. Cisapride. A for amiodarone. Amiodarone. T for sorry. T for terfenadine. Terfenadine. Okay. Okay. This amiodarone you can write here estimizole. Okay. We put it in the other way. So estimizole. What is this A now? Now I take this A. This is amiodarone. N stands for Navirs. Navirs. What is Navirs? Navirs are your protease inhibitors. Protease inhibitors. What do we mean by this is cytochrome 3A4 is that enzyme which is metabolizing those drugs. That means these all are the substrates. These all are the substrates for these drugs. And if you give, for example, I talk about rifampicin. Rifampicin is an inducer of this enzyme. So if it is an inducer, which drug should come into your mind while you are doing prescribing a drug to the patient is, you should remember that wait, you will say wait. What you will say? Wait. Once you are thinking to write a drug, you will say wait. What wait? Is it CT scan drugs? Is he already taking any CT scan drugs, or is he having the prescription of CT scan drugs? Calcium channel blocker, cyclosporin. You start thinking like this, tacrolimus. Oh yeah, I have to increase the substrate. So you will tell the patient, take the extra dosage of your already these drugs. I'll be able to understand. Because once I'm giving an inducer, that will increase the metabolism of that substrate by the enzymes. So cytochrome 3A4 is metabolizing these drugs. And once you are giving rifampicin as an anti-TB agent, anti-tuberculosis therapy, the patient has to increase the dosage of the substrate. You have to increase the dose of the substrate so that you can have the effective plasma concentration, effective potent dose, isn't it? So two things are asked about this cytochrome 3A4. Remember, two inhibitors and inducers. Inducer is St. John's wort, and inhibitor is grapefruit. Long back in an exam paper, I had seen they had written grape wine juice or something, and they confused you. They put two options in it, grapefruit juice and grape wine juice. They put two options in that, grapefruit juice, something like that. So remember this grapefruit. Okay, grapefruit juice. Okay, there are others also in the inducer part, that is benitoins, barbiturates, phenobarbital, and there are inducers also. By the way, I remember from this phenobarbital, this a thing from that. There is an enzyme in your microsomal enzyme, that is delta ALA. What is delta ALA? Yeah, amino levulinic acid, isn't it? Delta amino levulinic acid. It is that. What is this? This delta ALA synthase is basically increasing your porphyrin synthesis. It is increasing your porphyrin synthesis. Porphyrin. So tell me one thing. First thing I will tell you, this ALA is a microsomal enzyme. So will it have inducers? Will it have inducers and inhibitors? It is a microsomal enzyme. Will it have inducers and inhibitors? Yes, sir, it will have inducers and inhibitors. One of the inducer is phenobarbital, phenobarbital, phenobarb, or another is phenytoin. What is happening is, once you are giving this to a patient, it will increase the synthesis of porphyrin. It will increase the synthesis of porphyrin, meaning thereby, if a patient is already a patient of acute intermittent porphyria, means if a patient is already a patient of acute intermittent porphyria, means in this disease there is more amount of porphyrins in the blood. Will you give this drug phenytoin to this patient? No, absolutely contraindicated. It is absolutely contraindicated in a patient of acute intermittent porphyria. So remember, this rate limiting enzyme, which is increasing the porphyrin synthesis, you should not prescribe a patient the inducer, that is phenytoin and phenobarbital, if the patient is suffering from acute intermittent porphyria. Are we able to understand? So by the way, I remembered this from this phenobarbital. So this is the concept you have to remember. Today we have discussed about, completed the metabolism part. In the next topic, we will be talking about the excretion part and the pharmacodynamics. So if you haven't subscribed to my video, please subscribe, and I would be uploading more videos on all the 19 subjects of MBBS, that is Bachelors of Medicine and Bachelors of Surgery, the undergraduate medical course. Thank you very much. Bye bye.